Well, good evening and welcome to you. Thank you for taking the time to join us this evening. Hammy and I are presenting to you from Birmingham, where it's now early evening and a little bit dark outside. So if it looks dark in the office, I do apologise for that. We're going to be talking for the next half an hour or so about thrombopoietin receptor antagonists for the treatment of low platelet counts, thrombocytopenia, in Child-Pugh A and B patients, so patients with cirrhosis at the early stage who are undergoing invasive interventions associated with risks of bleeding. I'm a consultant hepatologist here at the Queen Elizabeth Hospital in Birmingham, and my colleague Hammy Mirzad, who's going to introduce himself now, works with me here at the liver unit. Hammy.
Thank you, Andy. My area of expertise is really interventional radiology, but in particular sort of hepatobiliary procedures. And we deal with a lot of these patients who have got low platelets. And really, the relevance of this talk is about how to deal with these patients, what best to do, and have a plan in place for them. So over to you, Andy. Thank you.
Many of my patients have low platelet counts. And that's for a variety of reasons, but mainly to do with chronic liver disease. In chronic liver disease, as the liver cirrhosis or non-cirrhotic process progresses, we see changes in the blood flow within the abdomen, and a syndrome called portal hypertension emerges, which is usually characterized by an enlarged spleen and changes in the blood count, particularly a low platelet count. And there are a variety of reasons for why the platelet count is low, but in many of my patients, it can be very low indeed, to the degree to which it can interfere with the interventions that are being proposed.
So my interest in patients with chronic liver disease is largely related to the fact that I perform a lot of procedures on these patients, and the importance of knowing about the thrombocytopenia again is related to being, as the operator, being able to gauge the risks of the procedure and any potential complications.
Most people like to have definitions which are easy to remember. So severe thrombocytopenia is usually characterized as a platelet count of less than 50 times 10 to the 9 per mil. Platelet count isn't the only factor to take into account. And I think I must say that to start with. Many of our patients have prolonged INRs because of their liver dysfunction. And so we have to remember that it's platelets and clotting factors that clot the blood. But the platelet is the tool that nature uses to start a clot. And so if you don't have enough platelets, or if your platelets aren't working, then we can have a problem because the clot won't form quickly enough. So getting the right number of platelets is vital, particularly in a more high-risk intervention. So how many is enough? Well, that is a much more difficult question to answer. Normally, we would want to see an increment of at least 50% in a patient to be able to go ahead with the procedure.
So there is a stratification of the procedures that we do to define the risk, and the procedures that in particular carry some risks are those procedures that may result in occult bleeding. So in particular, the type of procedures that carry the higher risk, I would say, is even a standard liver biopsy. I would also put into that category radiofrequency or microwave ablation of a liver tumor, and also a TIPS procedure for these patients with chronic liver disease.
So for most hospitals in the UK, a patient perhaps coming up to hospital for a liver biopsy with a low platelet count would be flagged up as requiring a platelet transfusion in anticipation of the procedure. However, in some hospitals in the UK, but also in other hospitals in Europe, we are seeing the use of platelet growth factors as agents which can be given in outpatients before the patient comes for their procedure to enhance the endogenous production of platelets and thus increase the platelet count in anticipation of the intervention. So those are the two main strategies that people would use to try and correct low platelet count. I think most of the audience will be very familiar with the limitations of a platelet transfusion. Most of the limitations are human and logistical and also the constraints that a very busy healthcare system sometimes can impose on planning interventions. So to successfully transfuse platelets, you have to order the platelets before, you have to set a date for the procedure, you have to make sure the platelets are delivered to the right place at the right time. That's not always as easy as it sounds. You also have to have the patient delivered to the right place at the right time, and that doesn't always go right. And so unless all of those circumstances are met, it's possible that you may have a patient ready for a procedure, but no platelets to give. The other thing which frequently happens, particularly at the moment, are that we have to adjust our lists. And so a platelets transfusion given for someone who thought that they were going first on the list, the patient may suddenly be swapped for emergency that's come in overnight. That patient might then be rebooked next week, but the platelets may have been given, or the platelets will be binned. And you can see how, even the best laid plans can go awry when emergencies are admitted through A&E in the middle of the night.
In particular, the limitations are really logistical. So one is to pick up the fact that these patients have got low platelets and thrombocytopenia pre-procedural, whether that's done in a clinic or a pre-screening scenario. But the more important part is then being able to dealing with that and making sure the logistics are in place, that everything is ready for the date of procedure. I mean, I'll give you an example. For example, I perform microwave ablation of the liver tumors on a Monday morning. That's the time I have with the general anaesthetist and a CT scanner. And we treat these patients with chronic liver disease quite regularly with ablation. Quite a few of them have got platelet counts that are below what we would normally go ahead with the procedure, and they will require transfusion. So you are reliant on these patients being admitted either very early in the morning, but more realistically the day before, and then having to come in and be seen by the ward team, be seen by the junior doctors, and all the logistics of having the platelet transfusion on time, ready for the general anesthetic of the morning of the procedure, and not having a delay. So that's the real challenge for these types of patients, and the challenge not only for the patient, but for us logistically to run an effective service.
I think the challenge is that platelets, when given intravenously, have quite a short half-life. They won't hang around for a week for your patient to come back to have the procedure rebooked. And so once the patient has had the platelet transfusion, really, you're committed to trying to find a slot either later in the day or the next day to be confident that the platelets that you've given will still be there. And even with that, you would still be wise to recheck the full blood count before you go ahead the next day. So those are the limitations with platelets. They don't hang around for very long. If a patient has a huge spleen, they too will get sucked up into the spleen like a giant hoover and disappear. And so unless you're prepared to rebook the procedure for the same day, the platelet transfusion often doesn't help you very much if you're having to rebook for later in the week. And unfortunately, that's becoming more common because access to interventional radiology has become very, very difficult following COVID due to some of the restrictions and resource limitations that have followed that particular pandemic. TPO-RAs are agonists of the thrombopoietin receptor. And the thrombopoietin receptor is the big on switch which the body requires to start to generate platelets. So these drugs are artificially produced potent agonists for the thrombopoietin receptor, and they give a good hard prod to the bone marrow effectively to make it produce more platelets from the megakaryocytes. There are 2 drugs available on the market for use in patients with thrombocytopenia and liver disease. One is called lucitrombopag, which is the first drug to get a license for use in liver disease, and then a more recent drug called avatrombopag, which is also a thrombopoietin agonist. There are slight differences between the way that the two drugs are used. Lucitrombopag is given for 7 days, 3 milligrams once a day as a tablet. It doesn't need to be taken with food, and you are able to proceed with your interventional procedure at day 9. Avatrombopag is slightly different. This drug has to be taken for 5 days and needs to be taken with food, and that is a strict license criteria. And then you'll be able to start your procedure at day 10 to day 13.
I think it's very important that we have a very simple algorithm if we were going to change patients from coming in to have a platelet transfusion to an oral preparation. And one of the advantages I see with lucitrombopag is that simple algorithm for both the patient and the clinician taking the medication. So it would be one fixed dose for 7 days and then wait till day 9 and afterwards before you perform the procedure. So I think that's a very simple algorithm to keep, which will, in the mind of the patient and also the clinician, and will reduce the complexity for the patient, and also hopefully increase the compliance, which is an important aspect to remember.
So the L+1 and L+2 studies were novel studies looking at the use of lucitrombopag in patients who were undergoing a variety of interventions.
Looking at the L+1 and L+2 studies, there was a list of the procedures that were performed. The first thing to note is that the invasiveness of procedures in the L+1 study was more than those in the L+2. So there were more invasive procedures, which probably represents more the kind of field that I'm in and the type of procedures that I perform. What I would say between both studies is the amount of liver biopsies done probably is slightly underrepresentation of the amount of liver biopsies that's happening. But in terms of the invasive procedures that I perform, such as microablation, transarterial chemoembolization, certainly that was well represented in the L+1 study.
So the two studies were slightly different, but both showed that in the groups of patients being studied, a significant proportion of patients avoided rescue therapy or platelet therapy to be given prior to the procedure. So in L+2, to give you an idea, nearly 65% of patients who received lucitrombopag avoided platelets or rescue therapy, as compared to 30% of the control arm. And in L+1, the same figures were 75% of patients who received the drug avoided a platelet transfusion, as opposed to just 12% of patients who received placebo. So when you amalgamate the two sets of figures, the top line is that if you're given the drug, 70% of patients don't need to have a platelet transfusion or avoid rescue therapy, whereas only 25% of patients, or under 25% of patients, avoided platelets or rescue therapy. So it showed that there was a very significant improvement in platelet count, which meant that these patients didn't require platelets to be given prior to their procedure, whatever that was, and didn't need to have platelets given afterwards as part of rescue therapy. So probably the most interesting slide from the L+1 and L+2 data is the combined or pooled analysis, which has shown that the platelet count rises after a patient has completed their 7-day course of therapy, but stays elevated for up to 3 weeks after that course of therapy is completed. Now, that's a game changer, because anyone will be able to tell you that platelets infused into the blood will not last for 3 weeks after the infusion. And so this is potentially of interest to us as clinicians, as it gives us a much longer window of intervention where we could potentially book a patient in for a procedure, knowing that we may have up to 3 weeks where the platelet count is above 50, which would allow us to go ahead.
And I think it's important to remember that having a sustained increase in your platelet count is a very helpful thing for the operator, but in terms of having reassurance that the platelet count is not just a fleeting thing, such as you would have with platelet transfusion, but this was a sustained period of increase in platelets, which will allow you to then either plan the procedure or plan further procedures if necessary.
In the ADAPT 1 and 2 studies, the findings were very similar. The studies were slightly different in that the patients were stratified into those patients with really severe thrombocytopenia, which is defined as a platelet count of less than 40, and those with more moderate thrombocytopenia, which was a platelet count of between 40 and 50. But as you can probably see from these slides, in both groups, even those patients with very severe thrombocytopenia, there was a significant rise in platelet count. And in those patients undergoing procedures, it was much more likely that patients would not require a platelet transfusion prior to therapy and would avoid requiring any form of rescue therapy after their therapy if they had received avatrombopag prior to their procedure.
When looking at TPO agonists, and in particular the difference between lusotrombopag and avatrombopag, for example, in the studies in the L+1 and the ADAPT studies, the key things really that stuck out for me were the fact that there was a different algorithm and a different dosing regime in the ADAPT study. So patients were stratified into two groups depending on their platelet count, and they were then given different dosing. And as I mentioned earlier in the talk, the key bit is to keep the algorithm as simple as possible, not only for the clinician, but for the patient. And I think that's where I see the advantage of lusotrombopag, where it's single dose given, and that, is a simpler algorithm to follow. The other key part really that came out of that study for me is that the number of days where you could have a elevated platelet count and a window of opportunity to perform a procedure.
Clinicians will always be concerned about drug safety, particularly in a drug that is going to potentially increase a patient's propensity to thrombosis. That's of a particular concern in liver disease, as paradoxically, liver patients have an increased risk of thrombosis, despite the fact that very often their in vitro measurements of clotting show a propensity to bleeding. Thankfully, in the lusotrombopag studies, the L+1 and the L+2 studies, there was no significant increase in the side effects of patients who were taking lusotrombopag compared with those patients in the placebo arm. But as a liver specialist, I would be particularly concerned about the risk of splanchnic thrombosis. In patients with liver disease, there's always a risk of portal vein thrombosis, but the two studies look very, very carefully at the portal vein and also sources of other splanchnic thrombosis, such as the mesenteric vein, and so saw no significant increase in thrombosis in the group of patients who received the lusotrombopag. So I find that very reassuring, because that would have been a major concern for me, but the studies very carefully looked for signs of thrombosis and were not able to find an increased risk of thrombosis in those patients receiving this drug. Lusotrombopag has been recommended by NICE as an option for treating patients with a low platelet count who will be undergoing invasive interventions related to their liver disease. In addition, the new BSG guidelines on liver biopsy have also recommended that clinicians consider the use of thrombopoietin receptor agonists in treating patients with thrombocytopenia. So both the BSG guidelines and NICE now recommend that clinicians consider the use of these agents in appropriate groups of patients.
The key differences between the two oral therapies, which are lusotrombopag and avatrombopag, from my interventional radiology point of view, is the duration of elevation of the platelet count. So what I mean by that is the period where after the dosing a procedure can be performed. From my understanding, the avatrombopag has a window of opportunity between 4 and 5 days where the procedure can be performed. This is against lusotrombopag, which has a window of up to 20 days. So a much longer window where the procedure could be performed. Now that is key, not only if that procedure is being planned, but if a second procedure is being planned, or there's a delay in that procedure. So I think this part will be a key determining factor between which oral dose or oral preparation is taken, and also will help tremendously with the planning and logistics and running of a service, and in particular running the lists, making sure that there's no delay and that the patient's procedures happen on time.
These are a very novel approach to managing patients who require invasive interventions in liver disease clinics. Also, we've never had the luxury of being flexible with our booking for interventions. And I think the data that we've discussed in this seminar has perhaps shown you that these medical therapies, which are taken as a tablet, as an outpatient, in anticipation of the procedure, will give a window of opportunity which is much longer than anything that a platelet transfusion can offer. Let's discuss a patient of mine who I was looking after last year, and we can think about what we might do to manage this patient's condition. So I was referred a 56-year-old man. He was diabetic and had a long history of alcohol problems and had been admitted through the A&E many times over the preceding 5 to 10 years. He was sent back to me because he developed jaundice, and the GP was anxious because the jaundice had started after he prescribed a new medicine. It's not normally a medicine that I would expect to cause jaundice, but you might look at the slide that's appeared on the screen now, and you can see that when we first met this man in 2011, his bilirubin was normal. But by the time he was referred back to me in October 2018, his bilirubin had gone up quite markedly. Perhaps the two things, though, that really struck me were the fact that his platelets had dropped quite sharply in those years that we hadn't been looking after him, and his renal function had deteriorated quite significantly, such that he had a creatinine of 239. We waited for his blood tests to come back, but they were all negative, and his ultrasound confirmed that his spleen was enlarged at 15 centimeters, which suggests that he has portal hypertension, and that's confirmed by the finding of ascites, which was visible down in his pelvis. So we had to find a way to be able to get a biopsy of this man's liver. Now, the first question would be, are you prepared to go ahead with those blood tests? The INR is 1.7, and the platelet count is only fractionally under 50, which is usually the cutoff for most people. And you might think to yourself whether you would or wouldn't go ahead, but in our hospital, our radiologists very sensibly said that they would prefer for his platelets to be adjusted and for him to have clotting factors to improve his INR. So the patient was given vitamin K, which is what we would normally do, and the biopsy was planned as an outpatient because we needed the inpatient bed back with a platelet transfusion on the day of admission. So I wonder what you would have done and what your hospital's normal practice is with these things. When I asked this question to a previous audience, nobody put their hands up to say that they would just crack on and get on with it anyway. But there was a choice of answers really for either bringing the patient in, checking the INR on the day and the platelets on the day, and then ordering those blood products if appropriate, or whether people would just proactively book platelets and book FFP in advance of the patient coming in for that. So our patient came in for his biopsy. So I wonder what you would do if you were faced with those blood tests and hadn't preemptively booked blood products. Would you carry on and hope for the best and perhaps order some blood products that you could give afterwards? I do know some people would try and do that. Or would you try and juggle the list? I think that's what most people do. So you move this patient to the back of the list and frantically try to track down a house officer to get a Venflon in and to send some bloods and to order the platelets and the FFP. And so it does beg the question, if you were able to give a tablet-based drug in outpatients in anticipation of a procedure that you knew would give you a 2-week window of opportunity, whether that might be better than the current management practice.
I want to just highlight a case to sort of show the things we've been discussing. The case in mind is a patient who's undergoing a TIPS procedure. It was a 53-year-old female with NAFLD. She had a 6-month history of ascites due to portal hypertension, and she required regular paracentesis. This was between February 2018 and August 2018. And she required 7 to 9 liters of paracentesis every 7 to 10 days. So that's quite a significant volume of ascites and also a number of procedures. Her diuretics were stopped and she had some sarcopenia, and her condition was slightly deteriorating. She had a massive ulcerated umbilical hernia, which needed a surgical repair. And we've seen 1 or 2 of these kind of patients in the past. If I give you an idea of her blood profile, so her platelets in February 2018 were 52, and as the year proceeded up to September 2018, they dropped down steadily from 52 to 49 to 42, and her INR was starting at 1.3 and went up to 1.5 by September 2018. Other thing to note is that her renal function also slightly deteriorated during this period. Her creatinine started at 100 in February 2018 and went up to 132. So she's got some renal impairment going on at the same time. The physicians had already assessed her, so they assessed her for the suitability of TIPS. They said that there was no encephalopathy, and that the patient's condition couldn't be improved any further, and this was the best time to undergo a TIPS procedure. And so they made a referral for TIPS as a bridge to surgery to improve the portal hypertension and reduce the risks prior to surgery. And the patient was referred to IR for assessment and to consider TIPS procedure. So just interested to ask the audience what they would do with that kind of picture and that kind of profile. Would they go ahead with the procedure, or would they turn around and say to the physicians that the patient is not fit enough? Would they think about a plan to improve the clotting and possibly admit the patient beforehand for a couple of days to, one, improve the clotting but also drain the ascites? Or would they bring the patient the night before and then deal with things on the morning? So this patient in particular was admitted the day before the procedure onto the general surgical ward. They had paracentesis and their blood pressure dropped after the paracentesis. What was also noted was that there was some bloody ascites noted in the drain. On the day of paracentesis, the patient's platelets was actually 43, and the INR was 1.5. But their creatinine function had continued to worsen and was 142. So on the day of the procedure, the patient was first on the list. We know that the patient had a bag of platelets overnight after the paracentesis as a result of knowing the low platelets and also the blood in the ascites. The patient's blood pressure on the day was 97/60, but the patient was not tachycardic. The key thing to ask really the audience is, what would they do in this situation? Would they go ahead with the procedure, or would they think about treating the clotting or anything further, or would they delay? So the options would be carry on with the procedure, give further platelets, wait for the blood count and the platelets to come back, or cancel the procedure and wait for a review by the physicians and to improve the clotting further. On the day of the procedure and after a bag of platelets, what we did note is the platelets were only 44. They'd only increased by 4. The key aspects from this kind of case is, could we have done something beforehand, or could the planning of the procedure be done better? to avoid any potential delay or cancellation on the day, or any reordering of the list. And I think that's where the key point to keep in mind is possibly having a pre-procedural algorithm and therapy beforehand would help. So if the patient was being given an oral therapy beforehand, where we knew that there was a sustained and continued increase in the platelet count, and they could undergo multiple procedures, that, for example, they undergo the paracentesis and the TIPS without requiring any further platelet transfusion, I think that would be greatly beneficial in this kind of scenario, not only in this case, but other cases that we would be doing, such as patients that require TIPS or radiofrequency ablation and multiple procedures. So that's where giving a oral preparation such as Lucitropic, I think, has a far greater advantage than relying on platelet transfusion either before the procedure or when things start to go wrong.
Well, welcome back, and thank you very much for joining us this afternoon. We've got a few questions which we'll go through now together, if that's okay, and do feel free to ask more questions as the discussion goes along. I'm going to start off with a topical one to Hami, which is, how has Hami seen COVID impacting on the booking and potentially cancellations of procedures, and where would the use of these agents have been helpful during the pandemic?
Thanks, Andy. We've seen quite a change in our practice, really. In the inpatient service continued pretty much as normal, but the outpatient elective service obviously suffered because of the COVID situation. The main issue being getting reliable COVID swabs in advance of the procedure, being able to admit the patient into the hospital. Those patients that required general anesthetic had to have a negative COVID test within 72 hours of the procedure. So all those logistics have caused problems and delays on the day. We've managed to continue some elective process. We've had to move some of it to a different hospital where the COVID testing was quite slightly more efficient, but we now, functioning fairly well. Where this would fit in, I think, is really largely services such as TACE procedures, RFA for liver lesions, and TIPS procedures, by saving patients the extra trip to the hospital or extra night in hospital in advance of the procedure. So, this can be prescribed remotely. They can be taking it without having to come in earlier. And I think, again, that helps really with the flow, because we've already got the complication of the COVID testing. This would have been an extra step for them to be in with requiring platelet transfusion. So I think that's where it would fit in quite nicely at this time.
No, I would agree with that. There's also a question, I think, about endoscopy. So I'm an endoscopist as well, and I have to say upper GI endoscopy in the UK has been affected much worse than colonoscopy. And as many people who are joining us will be aware, for liver patients, endoscopy is quite a common procedure, both for screening for varices and also banding. And I would have found it a lot easier had I had access to these drugs at the beginning of the pandemic, to be able to plan lists, which really have been very chaotic. And the projection going forward is that certainly in endoscopy it's going to remain like that because of the PPE restrictions. And so we're looking to move towards the use of these drugs in patients who would be requiring them with an indication for an endoscopy. So I think they will be useful, and it's for folks to write their protocols within their hospitals to know how to use them, which patients they would choose to use them in, how you would monitor them, etc., etc. But I think they do offer something new. There's a question that I've just seen coming in here. It says, does Molplio need to be dosed differently according to the platelet count?
Molpelo, it does not need to be dosed differently. Basically, it's the same dosing throughout, irrespective of your platelet count, basically. So there's no differential dosing for Molpelo.
Also, a related question there, which is about drug interactions. Now, yes, you can have drug interactions, and it won't surprise you to know that the main problems are with the CYP450 drugs, so both inducers and inhibitors. And there are some drug dose adjustments that are recommended for drugs which are recognized to interfere with that pathway. So there is a learning curve and some caution, but I think with these patients, we know to be cautious anyway. These are often quite fragile patients. In our own hospital, for instance, we are not going to use these drugs initially in transplanted patients because we'd like a little bit more data there, and we worry a lot about the hepatic artery and thrombosis. And also these studies excluded people with very, very slow portal vein flow. And so in our trust, Hami and our other radiologists very kindly tell us the portal vein flow rates, and so we use that to judge which patients we would not use these agents in. But it would still be the vast majority of our well-compensated cirrhotics who would be eligible for use, but it's worth having a protocol in place. There's another question here for you, Hami. If procedures go as planned, are there any advantages to having platelets elevated for up to 3 weeks? I think I know the answer to this one.
Mm-hmm. There certainly are. I think the procedures can go as well planned as you'd like, but there are always going to be some kind of late term complication, or the patient may require a second procedure a few days in their inpatient stay. And the advantage of this is that you've got that period of cover where even if it's a simple procedure, you don't need to be concerned about the platelet level. If it's a drainage or something like that, they may have developed a pleural effusion, let's say, that needs draining or whatever. You've got the reassurance that you've still got the platelet level at a satisfactory level to go ahead with the procedure. So I think that again makes the logistics of it much more useful and helpful.
Yeah. I would think of an example as with paracentesis. In some of our patients who have very low platelet counts with paracentesis, it's not uncommon, particularly if it's a bit loculated, to find that your first drain doesn't get enough out, and you might want to bring the patient back after the weekend or next week. And I think using these agents, you stand a reasonable chance of having a high enough platelet count to allow a repeat drain without having to go through the bother of rebooking platelets and what have you. So I think it's one of those things where once you start to use it, you find more and more reasons for liking the sustained platelet count. There are concerns about portal vein thrombosis, but I think the trials are very careful, to exclude people who are extremely high risk of portal vein thrombosis. But in those patients who receive the drugs, the safety profile appears to be acceptable. So I think it's just knowing who you wouldn't use the drug in, and being cautious in selecting patients from clinic. Hami, I don't know whether you've got any other thoughts.
I think it's something that can change our practice, and this allows you to in clinic pre-plan which patients you could prescribe this medication to, and make the ease of the procedure, the date of the procedure. The last thing you want to do on a day where you've got a list full of things is really be dealing with all these other things. Is there delay in the platelet count, a transfusion, when is it going to happen? Where do I juggle all this in? So, I mean, anything that helps ease the day, planning your procedures and planning a list, whether endoscopy or interventional radiology, I think that's a real benefit in this, really.
No, I'd agree with that. And certainly times are very unpredictable at the moment. So, there are definite advantages to having this on your formulary and a protocol for use in your department. The other thing I think we would add, which is perhaps so obvious that we've not mentioned it, we probably should, is that the protocol that we wrote jointly with interventional radiology and also with our hematology colleagues to make sure that everybody had agreed the way that we were going to use these drugs. And I think that's probably quite wise, isn't it, Hammy, to make sure that there's a pathway for these drugs to be prescribed. But as Hammy mentioned earlier, lucid Trombopac in particular is a very, very simple prescription. And so we have a system here where we have a consent clinic for interventional radiology. And so giving the prescription at that time is almost ideal, isn't it? So that patients can pick their drugs up when they go home, and you can actually tell them the date on which to start taking the tablets. Also, the companies will offer some apps as well, which patients can use to remind them when to take their tablets in the build-up to the procedure. So there are a variety of tools which can be used to make sure that things don't go wrong. But actually, these are very simple dosing systems, and it would be quite difficult, I think, for most patients to get it wrong, bearing in mind that sometimes our patients are prone to encephalopathy. I don't think there's any more questions, and so I know all of you will have evenings that you want to enjoy. If you're in the UK, you won't be able to do very much this evening because we're in lockdown still here in the Midlands. I'm not sure what the circumstances are where you are, but from Hammy and I, thank you for joining us this evening, and travel safely, and hopefully we'll meet in better times. Bye-bye.
Thank you.